Kanchana, in one minute. Okay, we are YouTube live also now. Yeah.
Greetings and welcome everyone. As a monthly initiative, Student Council 2021 is organizing an online continuous medical education talk for the greater benefits of the students of Manipal University College, Malaysia, under the guidance of our student advisor, Prof. Dr. Som Subade. And foremost, I would like to ask Vice Chancellor of Manipal University College, Malaysia, Prof. Dr. Adi Negara, Dean of Faculty of Medicine, Prof. Dr. Nachiappan, Director of Clinical Studies and Student Affairs, Prof. Dr. M.V. Kumar, and Prof. Dr. Som Subade for gracing us with their presence here today. Before we start, I would like to announce some ground rules for the CME talk. Please keep all of your mobile devices on silent mode. Secondly, please refrain from eating in front of the webcam. Please ensure that you're dressed appropriately, and throughout the talk, your microphone will be muted by the host and the co-host of the meeting. Please turn on your video to engage and interact with the speaker during the Q&A session. This meeting will be recorded and pictures will be taken for education purposes. By attending the meeting, you have given your consent for the recording and picture taking. We will now proceed with the picture taking session. Are required to turn on their webcam. Please turn on your webcams.
Do you all please on your camera? This is just for the photograph. After that, you can off the camera. Okay, we have 2 pages now here, so 167 people. So please on your camera one more time. Like we'll wait for a few more seconds to on your camera before we. Okay, look at this thing, camera and pose. Okay, 1 minute. Let me. Right, you can look at your camera and pose for a while in 3, 2, 1. This is for page 1. There's 2 pages, so just hold on to your pose. We'll see which page you come. Next page. In 3, 2, 1. Okay, back to you, Kanchana.
Thank you, sir. Now I would like to invite the Dean of Faculty of Medicine, Prof. Dr. Adi Negara, to welcome our speaker.
Can you hear me? Is it clear? All right, good.
Yes, sir.
All right. Yeah, very good evening. So we have Prof. Nachiappan, the Director of Clinical Studies and Student Affairs, Professor M.D. Kumar, and ladies and gentlemen, faculty, students, HODs. So on behalf of Professor Jaspal Singh, our Vice Chancellor of Manipal University College Malaysia, and also CEO of JVMC, we take this opportunity to welcome all of you here to this webinar session on the talk that is going to be given by one of our alumni, Dr. Senthil Nadan Subramaniam. All right. Dr. Senthil Nadan Subramaniam is currently attached to the Department of General Surgery, Queen Elizabeth Hospital, Kota Kinabalu. And I think, if I'm not mistaken, looking at his CV, he's actually undergoing the doctorate. Dr. Senthil, doctorate in general surgery, which would make him the first graduate from Manipal, Melaka Manipal, to be going for PhD with regards to clinical discipline. So well done, congratulations, Dr. Senthil. We have two other students in my knowledge going through PhD courses, but they are in the field of public health, Dr. Sudipta, and in the field of research methods, that would be Dr. Myron Godinho. So well done, Dr. Senthil Nadan. And just to inform all of you, we are in the midst of the COVID-19 pandemic, all right? And if you ask me, life was a bit tough for us for the past year. The first cases were noted in January of last year, so it has been 13 months since the first cases were spotted in Malaysia. All right, and we went through many phases from MCO, then conditional movement control order, RMCO, and in certain places you have the special kind of MCO where there are barbed wires, and you know, it has been gloomy. And in fact, in terms of teaching learning sessions, we were restricted in terms of movement, and we went through online sessions and so on. And you know, students also were a bit jittery, but you know, we would like to thank all of you, faculty and students, for the patience that you have and the perseverance. And in the midst of this gloomy news, we had two wonderful news coming up from the year 2020. The first is, of course, towards the end of 2020, just to inform all of you, Ministry of Higher Education finally granted us the award of University College status. All right, well done. And it was confirmed last month. Last month we had a very well, official ceremony of the opening of the University College status, and we'd like to thank the institution, all members, and especially Professor Dr. Jaspar Singh for facilitating, you know, the transition from college level to University College level. And just to inform, the other good news was in terms of the Department of Surgery. Okay, Dr. Senthil Nadan, you are in the Department of Surgery. We had two Manipal alumni achieving first in Malaysia. One of them, Dr. Arunasalam, a consultant urologist attached to Selayang Hospital. So he was in a team that, you know, operated on the largest kidney tumor removal, weighing at about 5.85 kg in Malaysia. So this was, you know, recorded as a world news, global news, because this kidney tumor removal could even be the largest in the world. So one of Manipal alumni, Dr. Arunasalam, was amongst the surgeons who operated on this removal. And the other one, just a few days later, in December of 2020, so the two events occurred in December 2020, another of our Manipal alumni by the name of Dr. Mohana Sundram Pillai, who is currently attached to the hepatobiliary unit in Hospital Selayang. He was in the team that performed the first living-related pediatric liver transplant. The first living-related pediatric liver transplant involving a living donor, the mother as the living donor to the child, and it was a 10-hour surgery was successfully done. So it also involved a Manipal alumni. So well done to these two Manipal alumni that, you know, performed two firsts in the country with regards to the largest kidney tumor removal and the first living pediatric liver transplant removal. And you know, for that we would like to thank all the Manipal alumni for, you know, working their hearts out. And of course, for this CME program, we would like to thank the organizing committee for continuously being involved in the facilitation of these CME sessions. You know, I was just talking with Prof. Som. We used to have a monthly event. Now it looks like it's a 2-weekly event. The last event was given by a neurologist, Dr. Neo Rajan, who is, you know, on the verge of being a neurologist. And this was just 2 weeks ago. So well done to the Students' Council, presided by Pervin, all right, who is the current president, Roshini, who is the vice president. Then we have the secretary, Vinit Kodin, and of course, Kanchana, who is the, you know, the evergreen master of ceremony for these events. And of course, the main person behind these Student Council's activities will be Prof. Som Subrade. Round of applause to Prof. Som Subra. He's our evergreen advisor. Dr. Senthil, maybe during your time, perhaps when you had this students council, he was still your advisor. Am I correct? So he has been our advisor from the day one the students council was initiated. So well done, Prof. Somsubra. We would like you to continue your facilitation of these events. And these events are important to us because, just for your information, the percentage of specialists in the country, it was brought to my notice that the largest percentage of specialists in the country hailed from the emblem Manipal. So be it Malacca Manipal Medical College, be it Kasturba Medical College in Mangalore, or Manipal itself, or Sikkim, and now Manipal University College Malaysia, we are proud to state the fact that the largest specialists in the country for the medical field, they are actually hailing from the emblem Manipal. And we would like the students here, please, carry, make sure that you have a directed vision after your housemanship. You can think about a certain, specialty. It can be surgery. It can be last month we had neurology and radiology. Could be public. It could be anything. But as long as you are directed, you will ensure all your efforts and your energy will be directed to that. And in fact, even if you were to change, it doesn't matter. Just to share my journey for a while, I was interested in becoming a physician, but later in my life, there was an opportunity to go into public health, and it stayed forever in me. So I mean, it doesn't matter as long as you are directed. And today we have Dr. Senthil Nathan, who would be talking with regards to his experience and his wisdom with regards to the journey of surgery. I hope some of you will be interested in joining that. Even if you're not going to join surgery, I mean, Dr. Senthil Nathan would be relating to his experience in how to go about going through the pathway of being a specialist, either through the examination system or through the master program. And so again, with that, we would like to thank the organizing committee again, Prof. Somsubra and the Students' Council. Thank you so much for having this program brought together. So thank you so much, everyone. Over to you, Kanchana.
Thank you, Prof. Now I would like to invite Prof. Dr. M.V. Kumar to say a few words.
Thank you. Thank you, Prof. Somsundar Dey, for having invited me to say a few words. Good evening to Prof. Adi, the Dean, Prof. Nachiappan, our HOD plus student clinical director, and the student leader Kanchana, all the other faculty. In fact, it's indeed a pleasure to say a few words to a fellow surgeon. It looks like a long time ago when he was being, harassed by me in the wards and in the classrooms. I still remember, I don't know whether he was in those batches where I put them through the mill both morning and afternoon in the wards. Did you have the MOA posting morning and afternoon where we used to spend?
Yes, Prof, I did.
Yeah, that's right. I mean, that was only one purpose. That was to try and toughen you guys up to understand that life as a busy surgeon or even a busy physician may not give you time for lunch, and you got to find your own time, grab your lunch, grab your tea, and you got to work very hard. But it pays off at the end because you get the satisfaction of having saved lives, really. I think this is one of the areas in the profession where every day there's an emergency and where you're called upon, and unless you do something straight away, the patient you may lose the patient. And yes, I'm very glad that you have stepped up to do the doctorate in surgery. I don't know of anybody else who has done PhD in surgery locally. The fact that you have chosen colorectal surgery, I think, is necessary to mention here that over the years, colorectal carcinoma or colorectal diseases have increased in this country, or rather, maybe the detection has been better. It was probably always there, but we detected them late because there was no awareness among the public. They came always a bit late. But now it's all being, sent in early. And I'm amazed that the amount of surgery which can be done laparoscopically now. I've seen a few videos, and they've got so good at it that they are faster than open surgery, right? And for the rest of you, he just mentioned that his wife is his classmate also from Manipal. Her name is Menaka. So I've told him to convey our regards to her. Well, there's a lot of future for people who take up any field. It doesn't matter what. Some fields, of course, you have an opening also in the private hospitals. The other fields, you will have an opening in the university setup. And yet other fields, you rise up, for example, in community medicine, you can go up to the level of World Health Organization if you so choose to. But of course, you must pursue and have the extra qualifications that are needed for the super specialist post that you may be aiming for. And these things don't come to you on a platter. The hard work, I can see that, the hard work that has paid off for so many of our alumni who have been now heading some of the departments in some of the hospitals. A lot of them have become urologists. I know of only you who has become a colorectal surgeon. A few of them have gone on to become specialists in emergency medicine. It depends on what openings you get. So I'm very glad and I'm very happy that you have come to give us a talk, though it is on Zoom and not face-to-face, right? It's still welcome. Thank you very much.
Thank you, Prof.
Thank you, sir. Now I'd like to invite Mr. Viswam to give a brief introduction of our speaker of the day. Thank you.
Thank you, Ms. Kanchana. Now I would like to introduce our guest speaker of the day, Dr. Senthil Subramaniam, one of our very own college alumnus of Bachelor of Medicine and Bachelor of Surgery in the year 2009. He then obtained his MRCS membership of Royal College of Surgeons from Royal College of Surgeons, Edinburgh in the year 2015 and pursued his specialty certification examination in general surgery in the year 2018 from University Kebangsaan, Malaysia. His work experience includes being a doctor of general surgery in Hospital Tuanku Jaafar in Seremban in the span of 2014 to 2018, followed by being a general surgeon there, and now he is currently the general surgeon and specialist in charge of house officers in Hospital Queen Elizabeth, Kota Kinabalu. His amazing achievement includes obtaining Sir Harry Anamantodo Gold Medal, Faculty of Medicine, for highest scoring UKM candidate in surgical postgraduate final exam. He has also authored and co-authored many research papers in leading medical journals and actively participated in medical camps organized by Mobile Court Sabah to give back to the community. He holds membership in Malaysian Medical Association, member of Royal Colleges of Surgeons Edinburgh, Sabah Surgical Society, College of Surgeons, Academy of Medicine, and in Persatuan Pendidikan Lanjutan Surgery Hospital Umum Sarawak. So without further ado, let's invite Dr. Senthil Subramaniam to begin his talk.
Thank you, Mr. Chairperson. I'd like to greet a warm welcome, a warm good evening to Prof. Adi, Prof. Nachi, Prof. MV Kumar, and Prof. Som, and all the Manipalites here today. It's actually very nice of the Student Council to have me over to have a few words with you all. Thank Prof. Som Subra for the invitation, and as well as Mr. Elvin, who has been in touch with me over the last 1 week. And I come to know that Elvin is also a Sabahan. So it has been actually quite a good interactive session with him as well. So today I have actually been invited to speak about the pathway of becoming a surgeon in Malaysia, right? And also giving you all a glimpse about colorectal cancers. I am an alumni from batch 14th. Yeah, I feel very old because now they say batch 47 is ongoing. So yeah, I do feel like a dinosaur now, but imagine the guys how they would feel if they're from batch 1. So Yeah, and so let me just share my slides here. Okay, can you all see my slides?
Yes, can see, sir. Can.
So, hi, Alvin. Yeah. So, I'm from batch 14, and the last I gave this similar talk was in 2015 during the MMMC PG Fair 2015. Even then, it was Prof. Som who invited me to give the talk. At the time, I was in my second year of Masters in General Surgery, and I had just completed my MRCS at that time. And the talk that I gave then and the talk that I'm going to give today is worlds apart. The content is totally different. The points in becoming a surgeon that were relevant in 2015 are no longer relevant today. And it will change by the time you all apply for your master's and your post-graduation. So I have updated the slides. What I may have mentioned in 2015 may no longer hold good today. So before I move on, let me just share this. Facebook reminded me yesterday of this. So it was a post that I posted on Facebook on the 10th of March 2012, 9 years ago. That's me saying that I met Prof. M.V. Kumar after so many years today, a gem of a person and a great surgeon. So in 2012, I was a junior surgical medical officer in Hospital Umum Sarawak, Kuching. And Prof. M.V. had come for Coloproctology 2012, a conference held in Pullman Hotel, Kuching. And I was part of the organizing committee because it was also organized by the surgical department. Of course, the medical officers do most of the work. And I met him there, and I was really happy to see him there. And I think that was the last I actually met Prof. MB. It was 9 years ago. I haven't seen him for the last 9 years. And I was actually very happy that he still remembers me by name. And even today, he still remembers me by name. So to me, it's an honor. Prof. MB, you are an inspiration and idol to me. I am who I am today partly because of you. So thank you so much for all those lessons that you gave me in medical school, and also for chasing me out of class for not shaving. And here I am today presenting in front of you, and sorry to say today also I forgot to shave. So, but yeah, I think now you can't chase me out of this classroom. Well, however, Prof. MV, I wouldn't be who I am today if not for you. So let's move on. So before I start, the most important thing that I want to tell you all is this statement here. So the subject that you fare best in medical school is not always the best field for you. Why do I say that? So I'll just give you a few examples. One of it is myself. So when I was in medical school, 3rd year, 4th year, and 5th year, particularly in Malacca, I was doing very well when it came to the subject of pediatrics, right? We had the Sunflower book. I don't know if you all still have it. It was called the Sunflower book. And I'm a person who likes to memorize. So I used to memorize, and I used to do very well in the exams. I think 2 semesters back to back, I topped the class for pediatrics. But I always thought that, since I'm doing so well in peds was my thing. And surgery in medical school was the only subject that actually made sense to me, right? The rest of the subjects was a bit of memorizing, a bit of understanding, was a bit of both. Okay, let's be very frank here. But surgery, I could actually understand. So, but since I was doing very well in peds, I never topped the class in surgery. So since I was doing very well in peds, I always thought maybe, peds is my way to go. But there's one thing in me that I always couldn't stand. I couldn't stand children. What more babies, right? So, but in medical school, you don't realize that because you don't have much contact with neonates. Mostly children, and mostly you have hand-picked cases where the parents will be able to give you a very good history, which is not the same in real life, right? Kids just tend to cry and they're not able to give you history, and half the time the parents are also lost. They are probably apprehensive, anxious. They also don't know what's happening. They can't give you adequate history, and it's just frustrating. I think pediatricians have a lot of patience, and I don't have that kind of patience. So that's when I realized during housemanship, my first posting I did was, I was the first posting houseman, pediatric houseman. And on the first day of housemanship, they sent me to pediatric oncology ward. Right, it was a subspecialty ward. We were only trained to take blood from adults in medical school. And here I am trying to take blood from oncology patients, oncology pediatric patients. And it was an experience, but over time we all learn things. And that's when I realized pediatric is not my thing, because I just can't stand children. And you cannot do something that you can only do something that you know you will be able to do till the day you retire, right? So it has to be something that brings you happiness. So that's why I mentioned this statement. The subject that you fare best in medical school is not always the best field for you. Another example is my ex-girlfriend, right? Today she's my wife. I was a match made in Manipal. Yes, her name's Menaka, as Prof. MV said earlier. So she, in medical school, always wanted to do ONG, right? Was always keen into ONG. She's doing very well in ONG. And when we joined housemanship, we did housemanship together in Kuching. And that's when she realized ONG is not her cup of tea either. Why? Okay, no offense, Prof. Som. But why she said that? It's not because of the subject. She loved the subject. But one thing she couldn't stand was the OT environment. The OT was just too cold for her. She's this small, scrawny character who doesn't have much of fats to insulate her. So she felt that, I can't do this till the day I retire. The OT is just too cold, and ONG is all about emergencies, going to OT. And she said, this is it. ONG is not my thing. And so now today she's a general physician. Actually, she's doing a subspecialty in cardiology. She's in a second year now. So that's also another reason why I say, if you're doing very well in a subject in medical school, yes, you may have your interest in that subject, but don't close other doors. Keep the other doors open. You will actually realize what is your subject of interest or field of interest when you do housemanship. Housemanship exposes you to what happens in real life. You probably even have a taste of it nowadays, since you all have shadow housemanship, right? Shadow housemanship will actually tell you what it's like when you become a doctor. So don't close other doors. Have a favorite subject, but be open to other opportunities that may knock your door. Okay. Next up is this slide. I'm sure all of you all would have seen this. How do you decide on your specialty, right? So if you look at this, some of it's funny, some of it, I don't know, I think they're just against surgeons. Anyway, so do you like nothing? How are your grades, right? And then if you like to cut, and what do you do on your free time? If operating is what you do on your free time, you should do general surgery. If you like penis jokes, you should do urology. This is actually a joke, but you should streamline basically your interests to find out which would be your field of specialization that you need to specialize in. Why do I stress on specialization? Is because the age and time today, if you don't specialize, you will not be able to survive, right? Being a general practitioner, yes, general practitioner itself can be a specialty. Family medicine is a specialty, but you will definitely need to pick up some specialization in order to survive in today's age and time. So the least you can decide at the moment is to decide whether you are a medical-based person or a surgical-based person. Do you like to see blood or don't you like to see blood? Okay. Do you like to see patients or you don't want to see patients, right? That's another thing that you can decide. Maybe you don't want to see patients. So maybe you can do radiology, so you have less contact with the patient, or pathology, right? Or if you want to see patients, but you don't want them alive, then maybe you can do forensic, right? So there are lots and lots of options out there. Okay, moving on. I will be speaking today particularly about the general surgery pathway and subspecialties under general surgery. Okay, so previously in 2015, when I gave my talk, it was always just general surgery, and you could only subspecialize after you were a general surgeon. Okay, this was an exception those days only for plastics, ped surgery, and cardiothoracic. Sorry, only plastics and ped surgery. But nowadays, things have changed. We have something called the direct parallel pathway program. So direct parallel pathway programs is basically a fast track to make you directly a subspecialist. You do not need to be a general surgeon first and then subspecialize later. Okay, so I'll be speaking about the Masters in General Surgery, which is still the only pathway to become a general surgeon in Malaysia. Sadly, this is true. The only way you can become a general surgeon in Malaysia is to go through the Masters in General Surgery. The Masters in General Surgery is offered by 5 universities. Local universities 4, Universiti Malaya, Universiti Kebangsaan Malaysia, Universiti Islam Antarabangsa, USM, and KPJ University College, right? UKM, UIA, and USM are government universities. KPJ University College is a private university college, right? So it's a 4-year program, and it confers you the title Masters of Surgery or Doctorate in General Surgery. I think Prof. Adi and Prof. MV misconstrued the Doctorate in General Surgery. It is not a PhD in General Surgery. However, what happened was, initially all universities called their degree a Masters in General Surgery. But over time, they realized that a master's program is something that you can achieve over 2 to 3 years, even without doing a thesis. And all these Masters in General Surgery program require you to complete a thesis, and it's a 4-year program. So they realized that it's more than masters. It's not masters, but it's a doctorate. So what is a doctorate? A doctorate is basically a degree higher than masters, but lower than PhD. It's in between PhD and masters, right? So UKM decided to rename their degree as a doctorate in general surgery. And the rest of the universities still call their degrees masters in general surgery. So basically it's the same, but it should be called a doctorate and not a master's. So this is a 4-year program. They give you a maximum of 7 years to complete it, right? It comes with a cuti belajar bergaji penuh. Basically, what does that mean? It means that you would be working and studying at the same time. You would be paid, but you would be also considered on loan to the university as a student, right? And it also comes with an HLP. HLP is Hadiah Latihan Persekutuan. So this is basically the scholarship that the government gives you in order for you to complete this master's in general surgery. Okay, I will be talking more about the scholarship and the criteria to be able to be eligible for the scholarship. So, okay, the peculiar one in this group of universities here is the KPJ University College. So KPJ University College is the latest kid on the block. I think they started their general surgery master's program 4 years ago in 2017, if I'm not mistaken. And KPJ University College started this program because Prof. Lokman Sayem, who was the previous dean of UKM, then moved on to become the dean of KPJ University College, and he created the MOU between UKM and KPJ UC. So you will need to quit Ministry of Health and join KPJ as a doctor, and then they will hire you into their master's program. You would be given a monthly pay by KPJ, right? But the pay, they call it a stipend. It wouldn't be as much as you would get under the Ministry of Health. If I'm not mistaken, it's about 4,000 plus ringgit a month for the duration of 4 years for the Masters of Surgery. And during these 4 years, they will rotate you between KPJ hospitals throughout the country, right? It might be JB or KL or Alostar. They will decide based on the surgeons in those hospitals who have volunteered to train, right? So part of your 4 years you'll be spending in KPJ hospitals training, and part will be in UKM. Basically, subspecialty rotations will be done in UKM, and the final outgoing conjoined board exam will be with all the local universities. And gazettement will be in KKM, and after gazettement, you will be bonded to KPJ for a certain period of time for under certain conditions. Okay. On the contrary, if you were under UKM, UIA, or USM, after completion of the course, you will be gazetting under KKM, and then you will then be bonded to the government based on the scheme that you were offered for the scholarship. I'll also be speaking on these schemes on the next slide. Okay. Why do I say it's the only pathway to become general surgeon in Malaysia, the masters? You might ask me, there is an FRCS international that is being offered at the moment. It's actually now called the Joint Surgical College Fellowships Examination, right? So a lot of people think that this FRCS is similar to the FRCS those days. If you look at the NSR accredited, recognized specialty degrees, yes, FRCS is recognized, but the FRCS that they mentioned there is the FRCS of the 90s. This FRCS International is basically an international recognition for the local postgraduate program. Okay, why do I say that? This is because if you want to apply for this FRCS, the requirement is to have a locally recognized postgraduate program, right? What is FRCS? FRCS basically is saying that you are equivalent to a day one consultant in the UK. That's basically what it says, right? And sitting for this FRCS after doing your master's in general surgery basically says that you are of the level of a day one consultant in UK. They're basically giving international recognition to the local postgraduate degree. Can you go and work overseas? No. Why do I say so? Because it only confers you an FRCS. They don't give you the CCST. You need a certificate of completion of surgical training, which can only be obtained after working in UK, for example. Okay. So for now, if you want to do general surgery masters, there's only one way out. You need to go for the masters in general surgery. Okay. But what if you want to do a subspecialty of general surgery? Let's talk about cardiothoracic. So there is a FRCS Cardiothoracic Edinburgh program currently in Malaysia. It's a 6-year course. It also comes with cuti belajar bergaji penuh and the government scholarship, Hadiah Latihan Persekutuan, right? It is a brainchild of the Ministry of Health, Malaysian Thoracic and Cardiovascular Society, and the Royal College of Surgeons, Edinburgh. Okay, they have a criteria for application. You need to have completed 6 months of general surgery rotation, 6 months of cardiothoracic rotation, and you should have completed your MRCS Part A and Part B. Okay, this is the first line of criteria you need to fulfill to apply. Then they also require you to have completed 2 years of confirmed service with Ministry of Health. Basically, you need to be an MO for 2 years, right? Then you have brownie points. If you have publications, it's all the better. Then good clinical practice course or any other relevant courses like basic surgical skill, right? Care of the critically ill surgical patient, ATLS, ACLS, BLS. And they also require you to be a member of the MedCBS Society. Okay, so this is a program that has started, I think, about 3 or 4 years ago. The first batch is still yet to graduate. So of the 6 years, you sit for the FRCS Cardiothoracic at the end of 4 years. And the last 2 years is for you to further subspecialize, or should I say super specialize, in your area of interest. It's like a niche area. So after 4 years, you get your FRCS CTH Edinburgh. Then you can choose if you want to do, say, minimally invasive cardiothoracic surgery or pediatric cardiothoracic surgery or just valve, aorta. You can actually pick your area of interest and continue to go on and do another 2 years abroad. And later come back as a cardiothoracic surgeon with a special interest in a certain field. So this is something new, and it creates a path for you to bypass the Masters in General Surgery program and become a subspecialist directly. So there are also other courses. One of it is the FRCS Urology, right? If you want to become a urologist, now you need not be a general surgeon anymore. You can just do it directly. It's a 6-year program. It confers you FRCS Urology. It's with the Royal College of Surgeons, Glasgow. And it also comes with the Cuti Belajar Bergaji Penuh and HLP, right? It's a brainchild of the Malaysian Board of Urology and the MUA, Malaysian Urological Association, Ministry of Health, and Royal College, Glasgow. Similarly, you sit for the FRCS at the end of 4 years. And the last 2 years, you can either choose to go abroad and do a niche area, or you can, it's optional. If you don't want to do, you can just serve as a urologist as well in Malaysia. The prerequisites for application is 12 months of general surgery, 6 months of urology, MRCS Part A and Part B. It's good if you have publications or posters related to urology and courses of basic surgical training courses like ALS, BLS, ATLS, CRISP, and the rest that I mentioned earlier. So when you apply for the FRCS Urology Direct Parallel Pathway Program, you'll have to undergo an OSCE, right? Once you pass an OSCE, you'll be put through a Viva and an interview. So if you pass the OSCE Viva and get through the interview, then they will take you into the program. And you'll be trained in Ministry of Health training centers for urology. There's a few, I think Selayang, Kuching, Alostar, and a few others. And at the end of 6 years, you will get your NSR urology. Although you complete your FRCS at year 4, they only give you the NSR 2 years later. Okay. Another good direct parallel pathway program would be the FRCS in plastic surgery. Okay, for plastic surgery, there are 2 ways of becoming a plastic surgeon in Malaysia. One is the Masters in Plastic Surgery. At the moment, it is only offered in USM. It is a 4-year program, similar to the Masters in General Surgery. You need a CBBP and a HLP. And at the end of 4 years, they give you a maximum of 7 years to complete. And at the end of 4 years, once you pass out, you'll be bonded based on the scheme that you were offered for the scholarship. But there is also a parallel pathway program. So you get to do an FRCS in plastic surgery. It's conferred by the Royal College of Surgeons of Glasgow. The good thing about the plastic surgery program, the direct parallel pathway program, is it does not need HLP for you to do. Okay, if you look at cardiothoracic and urology, they all require HLP for the scholarship. So for plastics, you do not need HLP. Why do I say it's good if you don't need the scholarship? Basically, if you don't get a scholarship, you're not bonded, number one. Number two, if you are not applying for a scholarship, there are lesser criteria to fulfill. So it's easier to get into the program, right? So, but you'll still be given Cuti Belajar Bergaji Penuh by the Ministry of Health. You need not quit Ministry of Health to join this program, but it does not require a HLP. So what are the downsides of not getting a HLP? So HLP basically pays all the costs while you are doing your specialization, right? So for this program, if you get in, the cost would be transferring between hospitals. It's a 4-year program, so you'll need to transfer between 4 hospitals. I think they have a few, I think they have 5 training centers. Penang, Alostar, Perak, Ipoh, Selayang Hand and Microsurgery, and Sungai Buloh. Okay, so these are the 5 centers. And if you were to rotate between the centers, you need to do 4 in 4 years. And you need to pay for your own transfers, you know, getting your things over, and your housing and all not and whatnot. Pay still goes on as usual, but if you have a scholarship, all this would be covered by the scholarship. You need not pay. And of course, the exam fee also you'll need to pay if you don't have a scholarship. So this is the brainchild of MAPACS, Malaysian Association of Plastics, Aesthetics and Cranio-Maxillofacial Surgery, Ministry of Health and RCS Glasgow. So there's no administrative or service criteria. Okay, what do I mean by this? Which means there is no minimum requirement of service before you can apply. Others say you need to be an MO for 2 years. Here, that doesn't hold good. The only thing that they want you to do is do 6 months of general surgery rotation, 6 months of plastic, and 6 months of critical care, right? So if you put that together, it's only 1.5 years. If you're lucky enough to complete this in the first 1.5 years of your MO-ship, you'll be able to apply. Right, you may ask me that nowadays MO-ship is a contract basis. It's no longer a permanent post. So for contract doctors, they're not allowed to get scholarship, and how are they going to become specialists? This doesn't hold good here either, because you don't need a scholarship, right? So if you're a contract doctor, and if you join this program, after about, your contract ends at 3 years of MO-ship if you complete your housemanship in 2 years, right? So if after 1.5 years you join this program and you are already in the program coordinators mentioned that Ministry of Health will extend the contract until your gazettement, until your completion of this program and gazettement, right? I'm very sure about this because I spoke to all the program administrators before giving this talk to make sure my content is actually legit. So they said, yes, ministry has given it to them that the contract will be extended. And the requirements they need besides this 1.5 years of service in these 3 faculties is MRCS Part A and Part B. They need you to complete your ATLS, care of the critically ill surgical patient program, and they want you to have a publication, right? So no bond. Once you complete, there is no bond. But however, the NSR for plastic surgery will only be given to you after you complete 2 years of service to the ministry as a plastic surgeon. So basically the bond is 2 years. It's not really a bond, but basically a compulsory service of 2 years before you are given your NSR and you can leave to the private sector. So this is a course that I feel is the best of the lot. It gets you in the fastest, gets you out the fastest as well. Then we also had the FRCS neurosurgery previously, which was offered by University of Malaya. I had 2 friends who completed it, but there are no more intakes and this program is now obsolete. There are no more FRCS neurosurgery intakes in Malaysia. So if you want to be a neurosurgeon, there's only one way, which is to do the Masters of Neurosurgery, which was primarily being offered by USM. You need a CBBP and a HLP to join this program. But of the recent years, University of Malaya also is offering posts for Masters of Neurosurgery. I think they take about maybe 2 candidates per year, and USM takes the most, about 15, I think. So for now, neurosurgery, there's only one pathway, the Masters in Neurosurgery. Moving on, okay, a bit more about the HLP. What is this HLP all about? I know it's a bit dry, but you need to know all this so that you can plan your way into the specialization program, right? These are things that you will not find on the internet, you will not find in books. That's why I've gathered this here for you so that you will be able to plan your pathway from now on. HLP is Hari Latihan Persekutuan, a government scholarship. So basically, they do not interview people before they give the scholarship. All you need to do to qualify for the scholarship is fulfill their criteria. The criteria they have a service and administrative criteria. So basically, they have this assessment, annual assessment by your superior, right? So your bosses will actually assess you on an annual basis and give you marks. So that's called sasaran kerja tahunan. Whether you are keeping up to your KPIs, are you achieving and performing, okay, up to par? And if you can attain a SKT score of more than 85% in 3 out of the last 5 years of service, right? So any 3, the highest 3, as long as you have 3 more than 85, that's one criteria. So technically that makes it that you can only apply after you obtain 3 SKTs, right? So the earliest you can apply is after 2 years of MOship. 1 SKT comes from housemanship and 2 SKT from the first 2 years of MOship. So that's when you can apply the earliest for this scholarship. Then you need to be under the permanent service. You can't be a contract doctor, right? I know it's a bit unfair for all the doctors who are under the contractual service. At the moment, everybody is being given contractual service by the government. But okay, let me just tell you this in my capacity as the vice chairman of National SCOMOS for the Malaysian Medical Association. We in the MMA and SCOMOS are working towards a pathway for the contract doctors to specialize, right? Whether it's going to be a permanent post with EPF or whether it's going to be extended contract for 10 years for you to be able to complete the specialization and gazettement, it's still in the talks. But we are positive and we are sure that we will be able to sort this matter out in the next 1 year or so, right? So by the time you all finish, hopefully we will have an answer to that. So yeah, carrying on from where I left off. So HLP is only for those permanent in service, and you need to be confirmed in service. Confirmed in service basically means you need to complete housemanship, right? And you need to get a permanent MMC number. You're only given a temporary MMC number while you're a houseman. And as I mentioned earlier, 2 years after confirmation in service for the 2 SKTs, at the time of application, you must not have any disciplinary action with the Ministry of Health, and you must not have turned down a similar scholarship in the past, right? Or have taken up a scholarship and have not completed the program or failed to complete the program for any reason. So the scholarship, basically, they only give you once. And if you turn it down or you fail to complete it, they don't give you the HLP again for the next 4 years. You can only apply after 4 years. But if you complete it, you can apply again for another scholarship, say for subspecialty. Okay, these are the service and administrative criteria. Then moving on to the training criteria. So each candidate, this is for general surgery masters, okay? So once you have obtained the service and administrative criteria for HLP, once you've gotten your HLP, now they need to decide who they are going to give the masters. So everybody, about 70 to 80%, everybody will fulfill the other criteria, the earlier criteria that I mentioned. But they can't take in everybody, right? So they need to filter the applicants. So who will be selected? So basically, now this is the latest training criteria. Previously, I think it was MRCS carried some weight, and interview carried 60% was basically based on interview and your CV, and 40% was based on an entrance exam, right? But it's no longer that way. The Academy of Medicine, College of Surgeons and Academy of Medicine have now decided that they will set a training criteria for those who are fit to be trained to become surgeons. So this is the latest training criteria. So each candidate that wants to do general surgery masters will need to have a coordinator. So this coordinator must be a member of good standing of the College of Surgeons, the Academy of Medicine Malaysia. And this coordinator, it's like a mentor-mentee program, right? So one candidate will have one coordinator for their basic surgical training. Basic surgical training is the surgical training that you acquire before you join the postgraduate pathway. The postgraduate pathway is advanced surgical training, right? So they have created an e-learning platform, right? It's basically collection of procedures which needs to be directly observed by your coordinator and assessed by the coordinator, and you're given marks for that. So basically, can you do a chest tube? Or can you insert central venous line, right? Can you do an appendicectomy? Can you do an incision and drainage? So basically, they have a logbook there for you, for your coordinator to assess you and give you marks based on direct observation, right? So that's the first 2 criteria by College of Surgeons. Next up comes the examinations, right? They give a lot of importance to MRCS Part A and Part B. It is now a norm that every candidate that apply actually has MRCS Part A. Some even complete the MRCS Part A and Part B before application. And the new kid on the block is the MEDEX examination. So the MEDEX basically is an exam by Majlis Peperiksaan Malaysia to replace the MRCS. It's only locally recognized, but it's basically going to replace MRCS for the examinations bit of this criteria. So how is MEDEX marked? So MEDEX marks are basically something like IELTS. So they go by bands. If you get 90 to 100, you get a band 6, 80 to 90, you get a band 5, 70 to 80, band 4, and so on and so forth. So you need a minimum of band 4 and above. Okay, so band 4, 5, or 6. And based on that, they will allow you to go for the interview, right? And the good thing about MEDEX is it's not like MRCS, right? So MRCS, if you pass, you pass. But MEDEX, you might get band 4, but then you might want to, say you get a band 5. And you might want to improve that score to a band 6. You might want to try again next year. But then you might be thinking, what if I try again next year and I get a band 4, right? So it would be a backfire. So actually, MEDEX doesn't work that way. They just want one result for MEDEX with the highest score. Okay, I think, if I'm not mistaken, it's 800 ringgit to sit for one attempt for MEDEX. And yeah, so you can go on trying with every attempt. And if you already get a band 6, then you can stop. Or if you get a band 5 now and get a band 4 later, you can use your results from the band 5, okay, to apply. Okay, then they also look at your participation in courses. Basically, these are the 5 main courses that they look at. It's courses that are really good to have. One is SOTM, Science of Tissue Management. Okay, basically general surgery is all about managing tissues. So how to handle tissues. Science of Tissue Management. This is a course by Johnson & Johnson with the Ministry of Health. So that's one. And then you have the basic surgical skill. This can be either done by surgical departments in Ministry of Health or by the Royal Colleges. I think Royal College of Surgeons of Ireland conduct it in Penang, and Edinburgh conducts it in Kuching and Sandakan, if I'm not mistaken. And you also have the non-operative technical skills for surgeons, advanced trauma life support, and care of the critically ill surgical patient. These 5 courses, if you have, it's a brownie point for you to get into the program. And they give a lot of importance to publication. Previously, it was just publication. You can publish in any journal, whether it's indexed or not. You can even, I know most of them were actually publishing in journals which were not indexed, because it's easier to publish in those journals. The criteria are lower. But now I think they've set the mark a bit higher. You need to have a publication in an indexed journal, right? So it's no longer what it used to be before. And they also expect you to present posters, whether it's an oral presentation or poster presentation in conferences, right? Be it international or national. And as for now, the Masters in General Surgery also still has an entrance exam, okay? What is the passing mark for the entrance exam? Okay, the entrance exam is a multiple MCQ, single best answer. It has negative marking within the question, but the negative marking is not carried forward to the next question. So the maximum mark that can be carried forward is 0, right? But if you get 3 correct and 2 wrong, you only get 1 mark. So that's how they mark that paper. And is there a passing mark for this paper? No. Okay, this is also something very different compared to normal exams. There is no passing mark for this entrance exam. So based on your marks for this exam, they will rank all the candidates that have applied from the highest to the lowest, right? And they will allow the top 60% to proceed for the interview, right? So the bottom 40% will have to try again the following year. You will not even progress to go for the interview, and therefore definitely you will not be able to get into the program. So the top 60% will go through an interview, and in the interview, they will look at your CV, they'll look at your surgical logbook, what you have done over the years, your working experience, your maturity, aptitude, attitude, and then they will make a decision whether you get into the program. So this is how it is for the general surgical master's program in Malaysia at the moment. Okay. And moving on, if you get selected, then now we talk about whether once you get selected, you can choose whether you want to do the general surgery masters as an in-campus candidate or an out-campus candidate. Okay, what is the difference? In-campus meaning you will be training all 4 years in a university, right? If you're a UM candidate, you'll be all 4 years in UM. UKM, USM, UIA accordingly, right? So the difference is previously, if you were in campus or out campus, there was a difference in the bond period and there was a difference in the payback as well. But recently, right, just starting the last intake, I think last year. So starting that intake, things have changed. So now it's no longer like before where in campus, your bond was 7 years and out campus, your bond was 5 years. It's no longer that way. So now whether you're in campus, out campus or combined program, the bond is fixed at 7 years. Okay. So as I mentioned, in campus means you will spend all 4 years of your master's program in the university. Out campus means you'll spend all 4 years in a Ministry of Health hospital, right? It'll be one hospital, a tertiary hospital, and you'll be doing your all 4 years there. If certain subspecialties are not offered in that hospital, you are allowed to go to a different hospital to do the subspecialty rotation. And they also have a combined program where you'll do 2 years in Ministry of Health hospitals and 2 years in the university. Okay, this combined program is only offered by USM, and UIA. Okay, and the completely all 4 years in a Ministry hospital is only offered by UKM for now. Okay, so for USM, UIA, and you can either do a 2+2 or you can do all 4 years in university. Okay, and now comes the bitter part of this master's in general surgery. So basically, you will be bonded to the government service for 7 years. Okay, and if you are a JPA scholar, then it adds on to your 10-year bond another 7 years. Okay, if you break the bond. Okay, what do I mean by break the bond? Means you complete the program, but you don't complete 7 years of service with the Ministry of Health. You leave to private, say for example, you need to pay back the government 350,000 ringgit, right? So this is the recent increase. It used to be 170 for in-campus and 100,000 for out-campus, but now they've increased it to 350,000 for all 3 systems. Right, and what are the other possibilities of breaking the bond if you don't leave the government service? So, okay, other ways of breaking the bond is not completing the Masters in General Surgery course within 7 years. They give you a maximum of 7 years or 4 attempts in any one of the exams. If you exceed 4 attempts or 7 years, then you will also be required to pay back. But that will be prorated based on the number of years you've been with the university. Okay, so now what I'm trying to say here is it's a fixed 7 years for all systems and 350,000 if you break the bond. So you can choose, you are given the choice, but the board is not obliged to give you what you have requested, right? You can always request and they'll ask you to justify your request when you go for the interview. But they will only give you based on availability of posts. Okay, so next up is my take-home message. Okay, for all your eager Manipalites who want to do general surgery. Okay, number 1, sit for the MRCS, right? The MRCS, you may think that it will be replaced by the MEDEX. Yes, it may be, but that's only in the local setting, right? MRCS carries a lot more weight rather than just being making you eligible to go for the Masters in Surgery program, right? So basically, what MRCS will offer you, if you do it now, as you grow older and older and you take up your Masters in Surgery and all that, it's going to be harder and harder to pass the MRCS. So better do it while your basic sciences are very strong. I did it in my first year of Masters. First year Masters is all about basic sciences as well. So basically in MRCS, later on, if you do subspecialty and you apply for a job in an attachment in UK, if you have an MRCS, you'll get a paid job. If you don't have an MRCS, you'll only get an observer job, right? Observer meaning you can observe, but you can't operate, which is basically pointless to me. So sit for the MRCS while you can, number 1. Number 2, if you can sit for the MEDEX, go ahead and do it, even while during your housemanship, okay? Yes, so second point, read Prof. MB's book, right? This is the Bible. Why am I saying this, right? I still read his book till today. I think now the book is published. It's green color, or I've seen one version that's green or one version that's blue, I think. Okay, my time, that book was not published yet, right? The Bible was not published. It was just merely printed half A4 size papers bound together. It was a Microsoft Word document that he gave it to us and we printed it and made it into a book. I read it for my medical student days. And then as a houseman, this book is the book that basically took me through my general surgical posting, right? And till today, I'm still reading that photostated book of mine, right? I have it somewhere here actually. So why am I still reading it today? I'm already a general surgeon. Now I'm taking classes for undergraduate medical students in University Malaysia Sabah, right? So I'm an adjunct lecturer for them. And I still read his book before I go for my classes because that book has everything you need in it, right? And let me tell you a story, how this book, why I always say that, I am who I am because of Prof. MV. I was a third, sorry, one second. Yeah, so I was a third posting surgical houseman in Kuching Hospital, right? At that time, my surgical posting, I was carrying this book to work every day, and I was always referring to it when I didn't know what was happening. So one day during rounds, I still remember Mr. Nick, my head of department in Kuching, he was doing rounds, and it was a patient post thyroidectomy. He was seeing that patient, all the MOs, the master students, and the housemen, grand ward rounds. Every Friday was grand ward rounds. So he asked the patient, "What's your name?" Basically, he was checking for hoarseness of voice. Then he asked the medical officers, "Do you know why am I asking the patient for his name?" Then they said, "Yeah, boss, you're checking for injury to the recurrent laryngeal nerve post-thyroidectomy. See if the patient has hoarseness of voice." So next, Mr. Nick asks the group of doctors, "So tell me, what's the supply? What does the recurrent laryngeal nerve supply?" So he asked all the medical officers. And to my surprise, then none of them could answer. They were giving him answers like it supplies the vocal cord. He didn't get the answer he wanted to hear. They were just saying it supplies the vocal cord and all. And he said, no, next. He just kept on moving and nobody could answer, right? So when nobody could answer, next they will start asking the housemen, right? So I was also there during rounds and he asked me, "So Senthil, tell me, what does the recurrent laryngeal nerve supply?" Then, it's a reflex to me. That question has been asked to me a million times in medical school, and it's a reflex to me, and I answered him. It supplies all intrinsic muscles of the pharynx except the cricothyroid muscle. And then to add on, I also told him the sensory supply, it supplies the sensation of the mucous membranes below the vocal folds. So these are things that has been ingrained in our memory in medical school, right? So it just came out as a reflex. And when I answered that, so that's exactly what he wanted to hear. He was really surprised, stood back a bit and asked me, "Senthil, are you interested to do surgery?" Right? He asked me that question. I still remember. And I told him, "Yes, Mr. Nick, I want to do general surgery." And he told me this, "How many months into the posting are you?" Then I said, "In my second month. I've got another 2 months to go." And then he asked me, "What posting are you?" I said, "I'm in my third posting." He said, "Oh, what a pity. You're only in your third posting." So he said, "Don't worry. When you finish housemanship, when you're in your sixth posting, come and see me. I will take you in as a medical officer in the Department of General Surgery, Kuching." Right? And that was the reason I am probably who I am today. When I finished housemanship, I went and saw Mr. Nick, and he very well remembered me for that one incident. And he took me in as a surgical medical officer. Some of my colleagues after housemanship, they went to district. I did not go to district hospital. I joined the surgical department in a tertiary hospital as a medical officer. I was there for a year. And after 1 year, I got sent out to district hospital for a while. And even then, just a few months later, boss wrote to Jabatan Kesihatan Negeri and brought me back to Kuching Hospital. And it's from then on that I applied for my master's in general surgery. I was in Kuching for 5 years, 2 years of housemanship, 3 years of MO there. Then I applied for master's in general surgery, and I did my master's as an out campus, all 4 years in Seremban Hospital. So I was in Seremban Hospital for 4 years, and then started gazetting. For gazettement, I got sent to Kota Kinabalu, and I've been in Kota Kinabalu for 3 years. So that is how Prof. MV's book has made me a surgeon today, right? So that small book has got a lot of power. Then next up, as I mentioned, shine during your housemanship. You need to be outstanding during your housemanship. Only if you are outstanding, people will be able to pick you out and let you excel, right? People will not come and knock on your door without you outshining the rest in your batch. Okay, that's number 3. Number 4, enhance yourself. As I mentioned the courses earlier, the 5 courses earlier, please enhance yourself so that you will be able to better yourself in the field of surgery. Just give me a moment. I think my battery is running low. 1 second. Okay. Okay. And then be ready for long working hours, like what Prof. MB said. You may need to skip meals, you need to go back at night. Being a specialist doesn't mean that you'll be able to sleep well at night. Being a surgeon, that is not going to happen. Let me just tell you all beforehand, it's not going to happen. Because certain things medical officers cannot do. Like appendicectomies, maybe they can do. Incision and drainage, maybe they can do. Once you're a specialist, you will still need to go in for all the emergency scopes. Middle of the night, somebody comes with upper GI hemorrhage. You will need to go in and do the scope. Patient needs a laparotomy, you will need to go in and do the surgery. So quality of life is not the best for surgeons, but it's very satisfying because you get to see the patient walking home, right? So be ready for long working hours, skipping meals, losing sleep, and being covered in various bodily fluids, right? Choose your specialty during housemanship. Now is a bit too early, like I mentioned earlier, right? Give yourself time, keep the doors open. Once you finish housemanship, you will know exactly what you want to do. I realized that I want to do surgery when I was doing my housemanship, right? Actually, I even gave neurosurgery a thought. But sorry, Prof. Nachi, but I have to say this. When I did neurosurgical rotation as a houseman, I actually realized that, when 10 patients come in, only one person walks out. The other 9 gets wheeled home. And then when they come to see you in the clinic, they were always on wheelchairs or stretchers. And it just didn't give me job satisfaction. That is not the satisfaction that I wanted. Although I knew if I become a neurosurgeon, I'll have a lot of money. But then again, money is not everything in life. You need that job satisfaction as well, right? And last but not least, be an MMA member. SMAMS, MMA is working hard to get the contract doctors an extended contract so that you'll be able to specialize. I'm saying this for my capacity as the vice chairman for SCOMOS. So please, all of you all, I know Malacca Manipal, last time when I was a student, all students are automatically made student members of MMA. Those days, we didn't even have to pay for it. I don't know how it was done, but I remember filling up the form when I came back from Manipal and I joined Malacca, right? Everybody was by default student members of MMA. Now, I'm not sure how it is, but I would urge all of you all to be student members of MMA. Join SMAMS, join MMA, right? So that is about becoming a surgeon. I'll let you all ask me questions later. Let me just rush through the part on colorectal surgery. Okay, why I chose colorectal surgery is because I'm looking forward to doing my subspecialty in colorectal surgery starting next year. And now March is also the colorectal cancer awareness month, right? So a glimpse of colorectal surgery, getting your rear in gear, right? So as you all know, I'll be speaking about, okay, these are the topics I'll be speaking on: a bit of statistics, screening for colorectal cancer, signs and symptoms, investigations, treatments, and follow-up and adjuvant therapy, right? So moving on, colorectal cancer is the second most commonest cancer in Malaysia, right? Breast cancer being the commonest, colorectal cancer is number 2, right? And if you look at based on the gender, colorectal cancer is the most commonest cancer in the male gender and the second commonest cancer in the female gender after breast cancer, right? And if we look at age-specific incidence, you can see that the incidence of colorectal cancer increases with age, and it becomes significantly high at the age of 60 to 64, right? It's about 61.5 per thousand population and 42.7 per thousand population in females, males and females respectively, right? So because the incidence becomes significant at the age of 60, we start screening 10 years before. That's why screening starts at the age of 50. But now we realize that the age is now coming down to 50, and we are looking at starting colorectal cancer screening at the age of 40. The lifetime risk, you can see that most people present in stage 3 and stage 4, a majority, okay? 66% of males present in stage 3 and stage 4, and 65% of females present in the later stages. So this is what we want to prevent. We want to catch them in stage 1 and stage 2 because the outcome is much better in the earlier stages, right? And you can see the ethnicity risk at the top. So it's a 1 in 72 for Malays, 1 in 39 for Chinese, and 1 in 82 for Indians, right? So the highest risk amongst the Chinese. And it's also quite high amongst the indigenous population in East Malaysia, Sabah and Sarawak, right? They tend to get young colorectal cancer, right? Their colorectal cancers tend to develop before the age of 40 even. That's what we notice in East Malaysia. And okay, screening tools, basically you can do screening for the mass population, or you can do targeted screening, right? So for the mass population, we do immunochemical fecal occult blood test, right? That's IFOBT. The specificity is about 93.6% and sensitivity is 99.1%. It's a non-invasive, right? It's because it's a screening test, it has to be non-invasive and it has to be socially acceptable, cost-effective, all the features of a good screening test, right? So IFOBT is the screening test used in Malaysia for all citizens above the age of 50, right? Immaterial of their risk factors. But if they have risk factors, then we need to do targeted screening. Then we start doing invasive screening, which is the colonoscopy, which is the gold standard screening tool for those with risk factors, right? As I mentioned, those with average risks are those above the age of 50 with no family history of colorectal cancer. So these people are screened with IFOBT, and those with moderate and high risk, basically those with family history of colorectal cancer, right? And those with familial hereditary colorectal cancer syndromes, right? Like your FAP, familial adenomatosis polyposis coli, right? And your Lynch syndrome. All these patients are in the high risk group and they will undergo screening colonoscopy directly. Next, what are the symptoms and how do they present, right? So as Prof. MV always says, right? So symptoms is what the patient tells you. Signs is what you pick up. So we have altered bowel habits and we have alternating bowel habits. They are both symptoms, but they are different. So altered bowel habits basically means that you have your normal bowel habit and now you have a recent change, right? A recent change in bowel habit means it has altered. It can be from normal to diarrhea or it can be from normal to constipation, right? Alternating bowel habits, on the other hand, is alternating between diarrhea and constipation, right? It's two totally different things and both are symptoms of colorectal cancer. Then you can have them presenting with rectal bleed, feeling of incomplete evacuation of stools. They can have mucoid stools per rectum and abdominal swelling, distension, or pain. Okay, why I didn't mention abdominal mass swelling? Because it is what the patient tells you. The patient won't tell you I have an abdominal mass, right? They'll tell you I have an abdominal swelling. Then they can also present with anal pain, swelling, and discharge, right? Perianal sepsis can also be a red flag sign for colorectal cancer. And then they will also have constitutional symptoms like loss of weight and loss of appetite, and anemic symptoms because of losing blood, even in microscopic amounts over a long period of time. They can result in anemia. So they may present with anemic symptoms. Then the signs first to pick up during examination. So the previous symptoms, you will ask for it during history taking, and signs are the things that you pick up during examination. So you will look for anemia, you look hard for it. Okay, anemia. You will also look for Virchow's nodes, supraclavicular lymph nodes, which is a sign of lymphatic spread of GI malignancy. So where do you look for Virchow's nodes? Basically between the sternal and clavicular heads of your sternocleidomastoid, right? That is where you find your Virchow's node. Then patient may have an abdominal mass, which may be the GI malignancy itself, or maybe just secondaries in the liver, causing a liver mass or a nodular liver. Then when you do a digital rectal examination, you may find a rectal mass, or you may find evidence of bleeding, right? Patients may also have hemorrhoids, okay? Hemorrhoids is seen on inspection, not on palpation. A digital rectal examination will not be able to tell you whether they have hemorrhoids. You need to see it, right? So hemorrhoids also is a red flag sign for colorectal cancer, especially hemorrhoids in elderly. Then perineal sepsis and fistula, as I had mentioned earlier, and cachexia, cancer cachexia, which is a late sign in these patients. Moving on, investigations, right? So you need to investigate them systematically. Blood investigations, your routine blood investigations. Specific markers for colorectal cancer would be carcinoembryonic antigen, CEA, right? There are levels for smokers and non-smokers, less than 5 in non-smokers, less than 10 in smokers, right? And then you need to do targeted investigations for these patients. So you can either do imaging. It can be a CT scan. It can be MR pelvis, right? Magnetic resonance imaging is done for patients with rectal cancer for the tumor staging. In your TNM staging criteria, the T staging for rectal cancer actually has to be done via MRI, right? For colonic cancers, CT is adequate. But for rectal cancers, you definitely need an MRI for the T staging. Okay. Now we also have endorectal and endoanal ultrasounds to look at the invasion, the depth of invasion of the cancer. And we also have PET scans to tell us about the spread. We even have PET CT and PET MRIs nowadays, which are combined to give us better anatomical delineation of the spread of the cancer. Then we also have endoscopic investigations, which is basically colonoscopy, which is the gold standard. We also have other adjuncts to colonoscopy if colonoscopy is not feasible in a certain individual. I will cover that in the next slide, right? And you also need tissue biopsy, histopathological examinations, which is also an investigation that you send. You take a biopsy of the tumor and you send it for histopathological examination. So if the patient can't go for a colonoscopy or failed colonoscopy for whatever reason, what are the alternatives to colonoscopy? So yeah, I remember this question was asked to me as in my end posting examination in Manipal, right? It was Professor Das Gupta at that time in 2008 or 2009. So Prof. Das Gupta asked me and I answered double contrast barium enema study. Then he asked me another question. So tell me, what are the two contrasts you're talking about? You said double contrast barium enema study. What are the two contrasts? Then I quickly said barium is one. Then he said, okay, what's the other? I didn't know. But okay, so now if you look at this picture, you'll actually understand the two contrasts and the two contrasts in this picture. One is barium, which is the white, and the black is actually air, right? So what he wanted to hear was actually air. So double contrast barium enema study is contrast between barium and air to see filling defects to identify colorectal carcinoma, right? Okay, that's one alternative. The other alternative now we have is CT colonography. CT colonography, basically you bowel prep the patient, right? You give them purgatives and then you give them rectal contrast to fill the colon with contrast. And then you do a CT imaging. And this is then reconstructed in a 3D mode by the computer. As you can see, then you'll be able to 3D reconstruct the entire colon and look for polyps or lesions. But the only downside of this CT colonography is it can only detect lesions bigger than 1 centimeter in size. So gold standard is always and still colonoscopy. Another alternative is a capsule endoscopy, which I have not mentioned. Okay, moving on from here, we have treatment options. Basically, these patients are treated with surgery, chemotherapy, radiotherapy, or targeted therapy. Okay, when it comes to surgery, we need to decide who do we operate on and who do we not operate on, right? We cannot be operating on everybody. So the decision is actually based on the stage and the location of the cancer. Okay, so stage meaning whether it's stage 1, 2, 3, or 4. T1, T2 tumors are stage 1, T3, T4 tumors are stage 2. Once they are node positive, they are stage 3, and once they have metastasis, they are stage 4. This is very basic for you all to know for an undergraduate level, right? Then it is also based on operability and resectability. What do I mean by operability and resectability? A patient is operable, a tumor is resectable. So means a patient must be fit to undergo surgery. That is operability, right? And a tumor must be resectable. That is resectability. So it is based on this that we decide whether the patient goes for surgery or not. In patients with cancer situated in the colon and upper rectum, they undergo surgery first, followed by adjuvant chemotherapy, right? I've put this very simply, very basic for you all to understand. If it's in the colon and upper rectum, you treat them with surgery first, followed by adjuvant therapy after surgery. But if the tumor is in the rectum, mid or lower rectum, you need to treat them with neoadjuvant therapy first, whether it's radiotherapy or concurrent chemoradiotherapy first, and then followed by surgery, and they may or may not receive adjuvant therapy thereafter. Okay, this is the two difference between colon cancers and rectal cancers. Upper rectum is still considered colon and they're treated like colon. Okay, that's one. But nowadays, if you're going for distinction viva, then I'll tell you this, you can impress your professors. Nowadays, we are talking about Foxtrot trial, a new trial that says that there is a role of neoadjuvant chemotherapy even in colonic cancers, right? But more for T3, T4 cancers and more for left-sided cancers. So if you want to impress your professors, you can tell them some trial names and I'm sure they'll give you the distinction. Okay, then who gets chemotherapy? Basically, adjuvant chemotherapy is for anyone who is high risk stage 2, stage 3, or stage 4. What do I mean by high risk stage 2? It means T3, T4 tumors. but they have risk factors, like they have lymphovascular invasion, perineural invasion, either they came in obstructed or the tumor was perforated. So these are all high risk features. So patients who are stage 2 with high risk features will need adjuvant chemotherapy, and stage 3 and stage 4 goes without saying, they will definitely need adjuvant chemotherapy. Right? Other types of chemotherapy besides adjuvant chemotherapy is neoadjuvant, as I mentioned earlier. Neoadjuvant basically means it is therapy that you give before surgery, right? So this is given in rectal cancers, T3, T4 tumors, and node-positive rectal cancers to shrink the tumor and reduce the chance of the tumor recurring in the pelvis, right? And then we also have palliative chemotherapy. Palliative chemotherapy basically is for unresectable metastatic disease. So as an undergraduate, if they ask you when will you subject the patient to palliative chemo, it's very easy for you all to say that if it's metastatic disease, this patient is most likely for palliative intent of therapy, and you can subject them to palliative chemotherapy. But in actual fact, you need to mention the word unresectable metastatic disease, right? Because metastatic disease is not the end of the road. We are now treating metastatic disease, and we can resect metastasis as well. So the keyword here is unresectable metastatic disease. These are the patients that we go for palliative intent. Okay, and we follow them up after surgery every 3 monthly with CEA, even if the CEA is not raised preoperatively, right? Meaning the tumor was not secreting CEA, but postoperatively we will still follow them up with CEA, because this tumor can undergo dedifferentiation, and if they develop METs later, the METs can actually produce CEA, right? So a low CEA value pre-op does not mean you need not do the CEA post-op. So we see them every 3 months with a CEA. We examine them clinically, and annually we do a CT scan for them. We do a colonoscopy for them. If the first colonoscopy is normal, then the next colonoscopy will be 3 to 5 years later. And after 5 years, if they don't have any more recurrences or metastasis, we label them as cancer-free, right? And they need not be followed up in a specialist center thereafter. So with regular close monitoring, signs and symptoms of recurrence can be identified and treated early. Okay, so spot the imposter, and thank you. Before I finish, I just want to say a last few words. I'm done with the presentation, but I want to just speak about this program by MMA. Sorry, I'm just taking some time here. I was told 7:30 is the last time I have. I have another 7 minutes. Okay. Yeah, so basically from MMA, for you all medical students, we are conducting this course called Financial Planning Seminar. We realize in MMA that doctors don't have formal financial training or formal financial education. So most of us are not financially literate. We are all financially illiterate. And we tend to invest by just hearing and getting advice from our peers. We are not making informed decisions like the decisions we do at work, right? So MMA has decided to conduct this course called the Financial Planning Seminar, so that you'll be able to receive the financial knowledge that you need to make informed decisions when it comes to investing, right? So we'll be talking everything about stock market investment, property investment, how much to cover yourself when it comes to insurance and income protection, mutual funds, unit trusts, and even cryptocurrency, right? We are not forcing anything onto anyone. The entire program will be neutral and unbiased, right? So there won't be company-sponsored speakers. It's all neutral experts speaking on this field, because we just want you all to know what is out there, okay, without involving much sponsors and third parties. So if you all are interested, you all can go to the website I've put up there, mmafps.com, and use the promo code MMA Boleh if you are student members. Student members and members, all of you all will get 50% discount. The terms and conditions are on the website. Feel free to go through it and register. There is a free session tomorrow at 6 p.m. I'll be moderating the session, so if you all are free, do join us as well, right? So thank you so much for this opportunity, and I will hand it back to the chairperson. Thank you.
Thank you, Dr. Senthil, for the very informative talk. This has definitely broadened our perspective on a career in general surgery, and I think we can all agree that the information regarding colorectal cancer was insightful. Due to time constraints, we have minimized the number of questions to which we want to highlight on. The remaining questions will be sent to Dr. Senthil via WhatsApp, and his answer will be shared later. Now I would like to call upon Mr. Alvin and Mr. Tarma to conduct the Q&A session.
Hello, sir. Okay, we have two questions here. The first one is, what are the common cancers according to age groups in your practice?
Okay, as I mentioned earlier, if you all see my slide, the commonest cancer in Malaysia is breast cancer, and number 2 is colorectal cancers, right? Followed by this, then we have thyroid cancers, upper GI cancers, and so on. I think a collection of upper GI, esophagus, and gastric put together would be the third commonest cancer that I see here. But peculiarly in East Malaysia here, what I see is a lot of these patients are in their very young age group. This is not the same in Peninsula. Peninsula, they are usually 50s and above. Here, they are actually 30s and above. It's a bit peculiar. Yeah.
Okay, sir. Thank you, sir. Next question is, what is the difference between Hartmann procedure and abdominoperineal resection?
Okay. So, okay, this is something that you all need to know as well. Hartmann procedure is basically removing part of the sigmoid colon, and it's basically for left-sided cancers, okay, not for right-sided cancers. So a Hartmann is removal of part of a colon and plus minus rectum, leaving a stump behind and performing an end colostomy, right? So the proximal colon is brought out as an end colostomy. You leave a stump within the pelvis, a rectal stump. That is Hartmann's. Abdominoperineal resection, you remove the entire colon and rectum, the sigmoid colon and rectum up to the anus, and you primarily close the anus. So there won't be an anus opening anymore, right? But this patient will also have a permanent end stoma. The sigmoid colon is then brought out as a permanent end stoma. So the similarity between the two is they both have a permanent, they both have an end stoma, but in APR, the stoma is permanent. And on examination, the patient will not have an anal opening, right? They'll have primary anal closure. That's APR. But if the patient has an end stoma and still has an anal opening, which means the patient most likely has gone through Hartmann's procedure, right? And Hartmann's procedure can be reversed. You can connect that end stoma back to the rectal stump in a second setting, right? But APR, that is the definitive surgery. That's the difference between Hartmann's and APR. I don't have a board to actually draw and show you all. If I can draw and show you all, it'll be a lot more easier.
Thank you, sir.
Thank you, Dharma. Now, Alvin, are there any questions from the YouTube live?
From YouTube live here, there is no question as such. So I can pass the floor back to you, Kanchana.
All right, thank you, Alvin and Dharma. Now I'd like to call upon Ms. Varsha to give the vote of thanks.
Thank you, Ms. Kanchana. First and foremost, Council, we'd like to express our gratitude. We thank Prof. Dr. Adi Negara, Dean of Faculty of Medicine, for making time to attend this talk, and also our respected lecturers that have joined our CME talk today. A big thank you to student council members for their efforts into making this talk happen successfully, along with guidance from our